Hi, good afternoon, everybody. This is Jeff Adest. I think most of you know me, but if not, I'm a partner here who I specialize in representing FQHCs for more than 20 years. And I'm here with Mick Stone, who is a partner as well, who used to work in the New York State Department of Health in the legal department, so brings a regulator's background to this topic. Before we jump into the topic specifically, just a couple of housekeeping items. Hopefully, if you've signed up for this and you've been getting our emails and you know that this is the second really in a series of 4 webinars. We had one a few weeks ago relating to the FQHC compliance manual, and then we have 2 more coming up over the next couple of weeks, one relating to 340B and one relating to FTCA. All those webinars are designed specifically for FQHCs and are not, generic to all providers. If you have ideas for more topics that you'd like to hear about that you haven't heard from us about, please let us know. You could post it as a question or send me an email or anything like that, and we'd be happy to address more topics that people want to hear. Also, again, I think if you listened to the prior one, you got this, but you should have received the slides today, and then within a day or 2 after this, you will receive an email with a link to be able to play back the recording, which is on YouTube, I think, and to the slides as well. So you could have other people who miss it, you could let them know about it as well. I will tell you that I was informed that the one we gave on HRSA compliance, new compliance manual, we had approximately 70 people who attended, and then another 100 people have watched it since. So if you think this is great and want your staff to watch it, you can use that link to be able to do it. So with regard to the topic specifically, given that compliance was due a few days ago, you might be asking, why are we giving this webinar now? And the answer, being honest, is that I didn't really view this as being legal driven. It was more operational driven. And so we were kind of going to sit this out and just help clients here, with specific issues that came up. However, over the past 3 or 4 weeks, we've gotten, numerous requests from clients saying, okay, I know we need to do this, and I know there's other resources out there, but I'm stuck and help me. And so we thought that what we would do today is, try to give you some practical guidance with regard to the requirements. What should yes, here's the requirement. What should I really be doing about it? And how do I show at least enough to be able to satisfy CMS were there to be a review? With regard to that, most of you would probably say to me, I can't remember the last time we ever had CMS come in to do a review, so do I really need to worry about this at all? So I'll say a couple of things about it. Technically, when you submit your FQHC application every 3 years, you're certifying that you have some kind of emergency plan in place. There has been a requirement for a PIN from a number of years already, but I'll say more importantly, we've been advised that the state's departments of health in various states are going to be incorporating this into their surveys. It's kind of like they do when they do surveys, they consider other federal rules. They're also going to be considering these. And I will say, at least in New York, we've been informed that, in the past, it's been very unusual for New York FQHCs to have DOH reviews unless there was a problem that led to it. But we've been told that DOH is going to start doing more reviews of FQHCs just randomly without, not just based on complaints. I will also mention, just as an overview, that we have FQHCs from various states that are on this webinar, so we are not going to focus specifically on New York or New Jersey. We're going to try to keep it generic. But I do want to acknowledge that, at least in New York and New Jersey, the FQHC associations, CHCANES and NJPCA, have programs in place and have documents in place, and we are not in any way trying to replace what they have. They have very good resources, and you should be contacting them to get whatever they have. What we're trying to do is, like I said, supplement and give you some practical ideas for how do I actually implement this based on our experience in dealing with FQHCs. With regard to the specifics of emergency preparedness, so I think this is a theme you've heard from me many times before. The federal government took what's really a hospital-driven rule and tried to, modify it and apply to other organizations, including FQHCs, and I don't think did the best job at understanding how FQHCs function when putting these rules together. I will say that I'm pleased, at least, that they didn't just tell you completely to comply with the hospital rules, which is what they typically do, and actually went ahead now and, tried to modify it to deal with how FQHCs function. But at the end of the day, while they did take out some of the more difficult hospital-based rules to follow, I don't think they took out enough. And as we go through it today, you'll see, from some of our comments that we understand this is very difficult for you to do. Just as an example, right, there's a requirement to have a community-based sort of mock emergency, test. And I don't know many hospitals that are going to be very excited when the FQHC in the area calls them up and says, okay, we've got to do this mock test tomorrow because that's what I want to do because CMS is telling me I need to do it. So as a practical matter, again, we'll give you some, ideas for how to show compliance or at least be close enough in compliance to make, to be able to satisfy a survey and, make it practical for how you live your lives. We also understand and acknowledge that this is just another burden thrown onto the FQHCs. Everyone's panicking about the fiscal cliff issues and things like that and telling me they're cutting staff and not hiring new staff. And now on top of this, we got to do this, which requires more work. And I guess, I sympathize, empathize, whatever the right word is. But at the end of the day, I don't know that we have, I do know we don't have a choice. We have to do some of it. I will tell you that we haven't seen surveys on this yet, so it's hard to say exactly. My sense is that it's not going to be that DOH walks in and finds that, you got 90% of the way and are missing a few things, and they say that's it, we're throwing you out of Medicare tomorrow and Medicaid. My hope is that it'll be more of a collaborative process where they come back and say, look, you got to improve this and you got to improve that. But we at least should be doing things now, right? I think most FQHCs that have the regular HRSA review and know that in the month before, you go ahead and you do a million things that you have to comply with, all the different elements, and we have a million documents that come in. The last board meeting is like 9 hours long because they have to approve everything. I would say that for this, I don't think that's going to work because when HRSA comes and does the review, they do it based on a minute in time. If you're in compliance when they come, then you're great. The fact that you were not in compliance a month ago is not something they look at. I'm not sure that CMS is going to view it the same way. So if you have a review in a year from now and the day before, for the first time, implement the policy or do anything, it's better than doing nothing, but I'm not sure they're really going to be okay with it. So I would tell you that at the very least, for now, you need to take some steps, doing risk assessment we'll talk about, preparing policies and procedures, doing some testing, some of the things that we're going to go through today, at least now. Also, just something to keep in mind is that when we go through some of these things, CMS keeps focusing on, well, what's going to happen if you have a problem at your site? You have to have a collaboration with somebody else who's going to take over your patient. Just something to keep in mind, and I know this does not apply to all of you, but many FQHCs have more than one site. So effectively, your collaboration could be with yourself, because if there is a flood at site A, your response could be, okay, that we're going to direct patients to site B and be able to treat them there, and not necessarily have to worry about having a hospital or somebody else who's going to pick up all your patients. Also, something to keep in mind is that the collaborations do not necessarily need to be with hospitals, right? They could be with another FQHC that's in the next town over from you. So this could be an opportunity for FQHCs to work together and learn best practices from each other. It also could be an opportunity with regard to the hospital, if you are going to work to develop a better relationship with them, which, depending on where you are, is sometimes difficult to do. So with that, turning to the specifics, I'm just going to mention that there are 4 different items that are required as part of the CMS requirements at a very high level. Now, I should mention also under state regulation, there were some of these requirements previously in place. Like I mentioned before, there was a HRSA pin about this in 2007. My sense has been that for many FQHCs, maybe back in 2008, they actually put something in place about it and haven't really updated it since then. and are pulling it now, blowing the dust off it to be able to take it back out now. But they do need to be updated. And even if you have something from back then, it's not good enough. You need to do a little bit more. Okay, so the 4 topics, and I'm going to turn it over to Mick right after this, are an emergency plan based on a risk assessment. That's, what's sitting down and figuring out what our risks are and what are we going to do if it happens. The second component is putting those into policies and procedures. The third is communication, and that applies both to your staff and to patients as to a disaster happens, where do they go? How do they know where to go? And the fourth one is the training and testing. That's training your staff and actually putting a mock test into place. And that's where the idea of having the community mock survey comes up, which is, I think, somewhat problematic, and we'll discuss a little bit later. And so with that, I'm going to turn it over to Mick.
Okay. You'll notice that, and throughout most of these slides, you're going to see that SOM Appendix Z on the bottom. That's the site to the State Operations Manual. Appendix Z, which is guidance that CMS issued on these regulations. That applies to all of the Medicare participating entities, including FQHCs. It applies to the residential healthcare facilities, hospitals, and a host of others, ambulatory surgery centers. So what we've done here is we've extracted the FQHC specific information from Appendix Z and put it here in a more manageable form. So the required action, and I'm not going to read through all of these. You have the slides, and again, you'll be able to see the presentation. But what we've done here is just put a brief summary, I guess, of the actions that you need to take in order to comply with the new emergency preparedness regulations. And you'll see that through here, there's Jeff has already touched on most of them. So getting to the emergency plan, the first thing that you need to do is the risk assessment. And again, that HRSA PIN that came out in 2007, that would have set you pretty far down the road to having the risk assessment. They called it back then a hazards vulnerability analysis. But if the underlying terms on this slide are the ones that we're going to be looking at a little bit more specifically. So the plan has to be based on, include a documented facility-based and community-based risk assessment, and it's got to use an all hazards approach. So again, the whole idea of the emergency plan is to help the facility anticipate what needs that might come up and support your continuity of business operations in the event of an emergency.
Sorry, just 1 second to jump back in. I forgot to mention at the beginning that if you want, there is some way to post your questions on the computer screen. Hopefully you can see where that is and be able to do it. There's a question box, and if we have some time at the end, we will try to address those questions. If you want to follow up after with questions, we're happy to take them after as well.
Okay, so first, the all hazards approach. What is that? It's an integrated approach to emergency preparedness that focuses on identifying hazards and developing emergency preparedness capacities and capabilities that address those, as well as a wide spectrum of emergencies or disasters. So yeah, I mean, all hazards means all hazards from their perspective. You have to be prepared for natural or man-made or facility emergencies. It could be care-related, it could be power failures, loss of some or all of your facility or loss of use of it, any interruptions in normal supply of essentials, interruptions in your communications. These are all things that fall under hazards that you need to consider. And the planning is you're going to be focusing on developing your capabilities and your capacities that are critical to the preparedness for a full spectrum of emergencies or disasters. You don't have to specifically address every possible threat, but your analysis should ensure that you have the capacity to address a broad range of related emergencies. You're going to probably prioritizing based on the likelihood of the occurrence and also on the severity of that occurrence. So those are, in terms of forming that, your risk assessment or your hazard vulnerability analysis, those are the things you're going to be focusing on. Think of those likely things for your area. So for instance, if you're in an area that might is subject to flooding, then that's obviously that's going to be high on your list. If you're in an area that if it has frequent power outages during storms for whatever reason, that's something that you're going to be addressing too. Depending on the condition of your facility, how susceptible it is, fire, any of those things that you might need to include in your assessment.
But just on that point, going to the not being based in reality, right? There was something in the commentary about that if you don't own your building, you need to be coordinating with your landlord with regard to what's going to happen if one of these things happen. I'm not really sure that many of your landlords are going to be all that interested in coordinating with you. And, if you want, we could help you with dealing with that. Some ideas might be just send a letter to the landlord or something like that to show some, good faith effort on your behalf. Also, this SOM that Nick is mentioning, so for all of you who have had HRSA site reviews, that there was a HRSA site guide that sort of was the basis for the reviewers to be and help you prepare for it. The SOM has the same kind of language in it. It actually has directions for the reviewers as to what they should be looking for. And so if you don't have it and you want a copy of it, just send us an email. Happy to send you a link to it.
And so the two types of risk assessment that you're going to have to do, again, is the facility-based and the community-based. So the facility-based is the one that's going to be specific to your facility. So you're going to be looking, again, at the ones that your facility might be particularly susceptible to based on its geographic location and your patient and community population, the type of facility, and your potential surrounding community assets. So that's rural versus large metropolitan area, and so the vulnerabilities that might arise from there. What's the response time to if you have an emergency at your facility? What's the likely response time from first responders to get to your facilities to assist you? So that's something you might need to think about as well. And also the second type is community-based. And they purposely did not define this in the regulations or the guidance. And the idea was that to allow you to be flexible in deciding what healthcare facilities and agencies are part of your community for the purpose of emergency planning. And it's not only within a state, but it could be multi-state region for some of you who are in kind of the tri-state area. You may rely on community-based risk assessment developed by other entities, but, and this was stressed multiple times, I think, in the guidance, that you have to have a copy of the risk assessment, and you must work, and that risk assessment, this is, again, the community-based risk assessment, must work for the entity that must work for your facility, as well as, the entity that might have taken the lead in developing it. So they have to be in alignment, your facility-based and your community-based risk assessment. And then so there is a guidance that was issued. There's a link to it here on this page from FEMA with respect to threat and hazard identification risk assessment guide. So that came out in 2013. However, and this is worth mentioning too, that's linked to in the ASPR website, which is the Assistant Secretary for Preparedness and Response for HHS. And they have a pretty good list of documentation that you can use. And basically they're saying, essentially that they're approving it. And if you follow this, you're going to be in good shape. And CMS too links to the ASPR site for that same reason.
Right, so just on that point, you may want to reach out to your local county Department of Health or somebody like that to see if they've done something like this where you could just get a copy of it. And yes, your individual one has to tie with theirs, but it's probably easier to change your individual one to tie with theirs than to get them to change theirs to tie with yours. but we've heard, from a number of clients that their local county has done something which at least, would satisfy the theory of what needs to be done, if not all the technical requirements.
And so for your risk assessment, here, I put together a brief list of what you should consider. So you have to consider those business functions that are essential to your operations that should be and could be continued during an emergency. Identification of all risks or emergencies that the facility may reasonably expect to confront. That's going back to what I was describing before. Identification of all contingencies for which the facility should plan. Again, kind of the same thing. So it's the facility's location you're also looking at. The extent to which natural and man-made emergency may cause the facility to cease or limit operations. And arrangements that may be necessary with other healthcare facilities or other entities that might be needed to ensure that essential services could be provided during an emergency. So that's kind of going to, if it's a community emergency, your facility isn't in any way impacted or taken out of commission. You're still able to operate and provide services. In what ways would you be able to assist? And we'll get into that in a little bit later. So with respect to the strategies that you would include within your plan, you're going to look at your staffing strategy, and that's with respect to if you're going to have staff shortages, and if you're going to have, which might be triggered by a surge in capacity due to perhaps injured people coming in as a result of the injury. And so your ability to assist with that. Also identify actions that will be taken for each identified hazard. So it's going to be specific to the hazard. You're going to say what, and that might be, there may be situations where the response is going to be similar or the same with respect to each different hazard, but you'll want to detail that or itemize that with respect to each hazard, just to show that how you're going to be addressing each one. So you're going to be identifying key staff responsible for executing the plan, define staff responsibilities. That's one of the things surveyors are probably going to ask you about. So who are the people who are in charge, and you're going to need to have an answer for that.
Right. Now, just to clarify on that point, that does not mean you need to go out and hire new staff to do this, right? The guidance is very clear that it could be people who have a regular job every other day, and just when an emergency comes up, this is their title they have. You have to document who those people are and what their titles will be for this purpose, but it does not mean hiring additional staff.
Right. And again, so your supplies and equipment, to the extent you need them at your FQHC, and sure your medical supplies, and you're planning for a situation, drugs to planning for situations in which maybe you might not be able to get deliveries for 3 to 10 days. Designate critical staff and provide for staff and volunteer needs during an emergency. So not only are you taking care of your patients, but you're also making sure that your staff are taken care of as needed during the emergency situation.
Right. So when I was reading this, I was thinking about, right, everybody remembers where they were on 9/11. But one of the things that just was, keeps coming back in my head is I was actually in the office when it happened, and I was driving home, and I was listening in the car, and I remember them talking about, all surgeons, please report to this hospital, to the hospitals that are around that. There was a call for surgeons and specialists like that, which goes to why the FQHCs are not really, the people, there was no call to go to the FQHCs to deal, to help out there. But where it could come up is in the aftermath of something like that, when people, the workers who were at 9/11 who got sick from it needed to be treated, right? There could be situations then, if that's something like that, God forbid, were to happen. Okay, now they're going to come to us for post treatment, so to speak. How do we prepare for that? What do we do for that? Could there be a need to call in volunteer staff? I think that's very esoteric, and I'm not sure that you need to have a real plan for volunteer staff or something like that, because hopefully that's a once in a lifetime kind of thing. But just as another example, I was talking to somebody this morning, right? If there's some kind of flu pandemic or something like that, where you got lots of people who are going to need to come in and get vaccinated and things like that, how are you going to deal with that? And that might be an easier one than worrying about the floods and the earthquakes and and things like that. They also did mention that you don't have to sit and have a list of 100 pages along every possible thing that could happen. It's
Right.
identifying the most likely things to happen.
Yep.
And being able to address those.
So also part of your emergency plan, you're going to be looking at your patient population and your continuity of operations. You're in every, depending on your community, depending on your facility's focus, you might have a specific patient population that may be impacted in certain ways from certain emergencies. So that's something that should be included in there. So it's something that you should be thinking about. Also, with respect to the continuation of operations. So I guess getting back to the point where there's the emergency, which most people think of in terms of the event, that particular disastrous event that happened. But emergencies can continue on after that precipitating event. And as Jeff was describing, might continue into, you have a lot, part of the emergency is due to people responding or people who are coming in afterwards who have been injured. So you have to think of the emergency in terms of that way, especially when with respect to continuity of operations.
Right. So I will just throw out something. I'm not really sure how this fits, but I anticipate getting some questions about it. Right. So there's been a lot of discussion in the past few months with regard to immigration and patients who are afraid to come to the FQHCs because they're afraid that they're going to be stopped and be deported. So I'm not sure, depending on when your review happens, if it's in the next 3 years, I'm not sure that CMS will be thrilled to see that as being an emergency that you found a way to deal with. Maybe after 3 years from now, that will be something they'll look at, but it is something, to keep in mind when you're addressing this.
And so that probably goes to the next slide, the slide with respect to the patient population. Your patient population might be undocumented immigrants and who may not be. You may have to do additional outreach for in the case of a disaster to make sure that they come in or epidemic in particular to make sure that they are treated and cared for. So when looking at your continuity of operations in your emergency plan, again, you're talking about the types of services that you can provide. You're not going above and beyond what you normally would be providing, but how you can assist given your resources in a particular emergency. They also, again, and I think I mentioned this a couple times, the succession planning delegations of authority. So it has to be clear who the person, and it has to be in writing in particular, who qualified person who's going to be acting in the absence of your person who's legally responsible for the operation, such as the administrator. So you're going to have to specifically identify which step or which staff would be assuming specific roles in another's absence. So that's what the succession planning is about. So you're considering in your continuity operations, who are your essential personnel? What are the essential functions of your facility? What are your facility's critical resources that you need or that you can provide? The vital records and IT data protection. How are you going to ensure that that you are protecting your records and your data? Alternate facility identification and location. So that's and again with respect to FQHCs, that was identified as in the guidance that it would constitute a change in scope request. They specifically referred you to the HRSA PAL 2014-05 for the change in scope requests. So they would expect you to go through that process too. And I think it would be on an expedited basis, obviously, due to the emergency situation. And also, of course, obviously, your financial resources too would have to be accounted for.
Right. So just something else to keep in mind is, when I come to FQHCs, I'm often talking about taking credit for the things that you're doing already. So this doesn't have to be that the world blew up. It could be that there was a fire in your building and now you have to evacuate people from the building, right? So I would hope that most of you have something in place, whether it's in writing or not, to deal with, we have a fire, here's how we're going to get patients out, and, here's what we're going to do with regard to that. And, when we get to testing later, doing something like a fire drill, could count for this as well. So if you have things like that you're already doing, don't forget to take credit for them and add them to your documentation.
And here's some suggested resources. Again, these will be in the slides that you have. They'll also be on the web, the posted webinar on the YouTube channel. So I won't read them out to you. The emergency plan also must include detail on cooperation and collaboration. So you're going to have that. It's going to include this integrated emergency response process, by which they mean process for cooperation, collaboration with the efforts of your emergency preparedness officials in the area, which would be local, tribal, regional, state, and federal, as applicable, to maintain an integrated response during a disaster or emergency situation. They expect you to be communicating and collaborating with your officials in this type of, you're not expected to be, not encouraged to be on your own. You're supposed to be continuing. So to that end, they want you to document efforts to contact these officials to engage in collaborative planning. So this would go to your community-based efforts for an integrated emergency response. And that integrated response process should be included in your emergency plan also. So getting back to the suggested materials, one of the suggested materials on the ASPR website did happen to be a resource that Chicane's actually put out, which is a guide for establishing relationships with first responders, community organizations, and local leaders for the purpose of emergency planning. So obviously, if you're looking for guidance, that would be a good resource for you to use. Updates. They have to be reviewed and updated at least annually. So make sure that that's done. I say at least annually because you may have an intervening event, and that might require looking at your emergency plan, which could include, your testing, your plan, which we'll get to later on.
Right. Just so I think as FQHCs, we're used to, having all these annual requirements to do once every 3 years, for HRSA. So I would just add this to whatever documents or ticklers you're using to remind you to do the HRSA requirements, to update this as well.
So now we're moving on to policies and procedures. So they have to be developed and implemented in accordance with the emergency plan and with your communication plan, which we'll get to later on in the presentation. The policies and procedures must include safe evacuation procedures. So that includes appropriate placement of exit signs, staff responsibilities, and needs of patients. Again, the exit signs, that was something that you had to do prior anyway under the old very brief emergency procedures regulation. But again, they stress it a second time here. So you're considering the evacuation protocols for not only your patients, but also for staff members and family, your patient representatives, or other personnel who have sought potential refuge at the facility. So again, this is a situation when they say potential refuge at the facility, you don't know what kind of disaster you're looking at and why people might have come into the facility for whatever reason, not just medical care, but also just to seek shelter, and they may need to evacuate. So again, you really have to kind of think outside of just what maybe protecting your patients, but also considering your staff, what your facility might be used for, who might also have showed up at your facility during the emergency.
Right, and this could be things like, it's like I'm sitting around the table over the weekend, and my kids are sitting and talking about, used to be had fire drills in school, and now you have all the drills, whether they're, shooter drills and things like that. And so if they're doing it in schools with little kids who know all about it and can tell you all about it, that's something that, should be considered. What happens if that happens in FQHCs? Over the years, we've had people who have come in armed and had to deal with that. And I think you probably all have something, in your head for how you deal with it, but now we'll be taking that and documenting it.
Yeah, and I think for most risk assessments and templates that we've seen, active shooter is on there. So its likelihood. So with respect to safe evacuation, going further, so you're looking at your specific patient population, and again, because these regs are kind of mixed in with others, obviously they stress parts that are more of an issue maybe for nursing homes, for instance. They're going to have more vulnerable patient population, but nonetheless, you should consider who your population is, what specific needs they might have, and with their mobility and their need for medications or other treatment that they look to you for. So, so when you're thinking about evacuees from your facility, you're looking at making triage decisions and communicating those your patient care to intaking facilities. So whoever's receiving your patient, if you're referring them or sending them to another person, this slide provides a process for how you do that. So sheltering in place is also a possibility. So you should have in your policies and procedures some obviously procedures that will let you shelter residents in place, not residents, but people, patients, as well as your volunteers, as well as your staff, and any other visitors who might be there, and to keep them safe in the case of a disaster, and that they might have to stay there for the duration of an emergency situation.
Right. So this is one to me that's really, more hospital and nursing home based that they missed when they were going through and trying to strip out the things to make it FQHC, because I really hope that you don't have patients staying in your facilities overnight, and at the end of the day, unless they're talking about a very short emergency, this is really not going to be too applicable to you. So I think because they left it in, you got to throw something in about it, but I wouldn't spend a tremendous amount of time focusing on this because it doesn't seem realistic.
Yeah, and consider, I guess, also a possibility that because you have health center on your door, that in the case of an emergency, you're getting people who are more appropriate for emergency room services and need to be transferred there instead. So that's a possibility too. So when you're talking about transferring patients, or they might show up there and they're your patients, but they are in a situation where they should be referred to an emergency room. So that's something that you should consider also as well and account for in your policies and procedures. Your medical documentation, again, you're not only preserving it, but with respect to sending it and making sure that it's readily available. So for continuity care, if you're transferring patients from your facility to another one, that you're able to do that in the most secure and most efficient manner.
Right. So I would think most of you have EMRs, and most of them are web-based, so this should be pretty easy. Again, you probably have a way for doing it, so take credit for it and include it, because this is an easy one to put it into place. If you have still, say, server-based and don't have backup sites or backup access, that's something that we should definitely talk about offline, because I don't think that's the standard anymore.
Use of volunteers, that should be addressed in there also, and how you're going to incorporate them in if you need that surge capacity. You would have an emergency privileging credentialing process. Note that there are federally state and federally designated healthcare professionals. You should reach out, obviously, to your emergency preparedness officials who might be able to direct you to those programs. I think we might get into those later on too. Well, here they are. So you have there's federally designated healthcare professionals, such as the public health service staff. So this is the list here. In New York State, there's a volunteer registry. It's called Serve NY, with medical healthcare professionals listed in there. I'm sure other states have similar volunteer registries as well.
Right. Just with regard to volunteers, to preempt the questions, I'm sure the questions are going to be, does FTCA apply to this? And given the breadth of information we had to cover today, we will be addressing that in the FTCA webinar in a couple of weeks. If you want information, sooner than that, just reach out and we'll be happy to provide it.
And also contacting your off-duty staff and event of an emergency to see who can report. This all should be accounted for in your policies and procedures as well. And again, review and update at least annually, and revise as necessary. So, communication plan. So this is the third, core element. Must be developed and maintained in compliance with the federal, state, and local laws. Obviously, one of the federal laws that they're talking about is, I think, HIPAA, but we'll get to that. So it must include the names and contact information for staff, entities providing services under arrangement, patients, physicians, other FQHCs, and volunteers.
Right. Just to jump in for a second, under arrangement is not a term that we hear in the FQHC world. This goes back to being hospital-driven. That's a specific hospital term. What that means to FQHCs is sort of the people who are on Format 5A in column 2, which is that someone's providing service to you under a contract, but at your facility. That would be the equivalent as what they call an under arrangement.
So they recommend in the guidance that you have contact information for facilities that are not FQHCs as well. The format for the contact information is up to you, but it should be readily available and accessible during an emergency event. So you're going to have to be able to show that to surveyors too. You can pretty much be sure of.
Right, and this one again, I would think that you probably have in place already, because if you have a snow day and you have to close the facility, you have some way of contacting staff to let them know, and so at least part of it should be in place. And now it's just a question of documenting how you do it.
Yeah. And so if your contact information is maintained electronically, you must be able to provide evidence of data backup with hard copies, or demonstrate capability to reproduce your contact lists or access to the data during the emergency. So this goes back to Jeff's point before. Also, it must be accurate and current, which means updated for incoming and departing staff and for other changes in information that may occur throughout the year. So you have to pay attention to it. It can't just be filed away. Keep it current. So it must include contact for federal, state, tribal, regional, and local emergency preparedness staff as applicable, and other sources of assistance. The format again is up to you, but again, readily available and accessible during the emergency event. And same, with respect to these sources of assistance, it should be in both electronic format and hard copy. Communication plan must include both primary and alternate means of communicating with your facility staff and emergency management agencies. You should consider things such as pagers, cellular phones, walkie-talkies, ham radio systems, satellite phones. So it should include procedures regarding when and how alternate communication methods are used and who uses them. So again, that's a specific employee.
Right, just on this point, I don't think it means you need to go out and buy a whole new system to be able to do it. Right, theoretically, your system could be, we'll use cell phones now. I think we all understand that depending on the nature of the disaster, cell phones may not work either. If you have, I'll say, a handful of walkie-talkies or some other devices, I think you're probably okay for satisfying this. I don't think it means you need to go out and give every staff member a walkie-talkie to take home with them every night.
Yeah. And so your alternate, and your alternate means of communication, if you're using like some sort of radio system, has to be compatible with other facilities, and so the guidance provides a brief list of systems that you can look into that are on this slide here. And so the communication plan must include means of providing information about the general condition and location of your patients, those under your care as permitted under the HIPAA regulations. So the what is your necessary patient information that is readily available, which would include name, age, date of birth, allergies, current medications, diagnoses, current reason for admission, that's if inpatient, which you won't have, blood type, advanced directives, and next of kin or emergency contacts. How are you doing it? There is no particular means for sharing the information, such as either paper or electronic. You must develop a method of sharing information, medical documentation that maintains continuity of care. That's the direction. When? You must send it with the evacuated patient to the next care provider within a time frame that allows for effective patient treatment continuity care. They stress that you are not to wait to assemble all the patient reports, tests, etc., to send the patient. Obviously, the proper care of the patient is paramount, not the extent or the completeness of the documents that you are able to send with that patient.
Right. So this one actually mixes well with the requirement under the new compliance guide, right? And it used to be that you had to have after-hours coverage. You did not have to have anything during the day. They've now changed it to emergency coverage. So you have to have policies in place for how you're going to deal with, a patient who walks in the door and collapses in the middle of the day. What's your policy procedures for dealing with that and sending them to the hospital and things like that. So some of the information that you use for that could be used for this and vice versa.
And again, getting back to HIPAA, note is the HIPAA rules, privacy and security rules, are not suspended during a national or public health emergency, but those regulations do include requirements for disclosing patient information to a public or private entity authorized to assist in disaster relief efforts. So there is a flow chart that has been put out that offers guidance with respect to disclosing protected health information in emergency preparedness situations, or for emergency preparedness purposes rather. So that's something we can provide too if you're interested in that. So the communication plan, you're also communicating your not only your needs but also your ability to assist other facilities. So it must include a means of providing information about facility needs and the ability to provide assistance to the authority having jurisdiction or the incident command center or designee. So what might that be? So the needs might include, from your end, you might need medical supplies, might need assistance with evacuations and transfers. How, again, no particular means is prescribed, but a process to communicate the required information must be included in the plan. So you have to set that out. Who are you communicating this to? Primarily to the Incident Command Center, as identified by local, state, tribal, or federal emergency preparedness officials, as well as regional healthcare coalitions who can assist the facilities in the identification of these centers and the reporting requirements. So the communication plan updates, as you may have guessed, have to be reviewed and updated at least annually. Okay, the fourth core element is the training and testing program. So your emergency preparedness training and testing program must be developed and implemented in accordance with, of course, the emergency plan, your policies and procedures, so that's what you're testing, and the communication plan. So the FQHC must provide initial training in emergency preparedness policies and procedures to all new and existing staff, individuals providing services under arrangement. Again, that's the language from the actual guidance, and Jeff clarified what that means. So your contracted providers and volunteers, and all consistent with their expected roles. So you don't have to overtrain everybody and everything. It's really specific to their particular roles at the facility. Emergency preparedness training must be provided at least annually. You, of course, must have documentation that the training and available to show to surveyors. Staff, etc., must be able to demonstrate knowledge of emergency procedures. So expect that a surveyor may ask a staff member specifically about what their role might be, for instance, in an emergency situation.
Right. So just for a second, with regard to training, technically that training had to have been done by last week, right? Because that's when the compliance was required. As a practical matter, I'm not going to ask the question, but I would imagine a lot of you did not do this training last week, because this is not just for the, the 5-6 people who are, security or who are going to be running this. This is an all-staff training. I would tell you that at the very least, at your next all-staff training or departmental trainings, whatever you do, you should be spending at least a few minutes going over, these requirements and what you're doing specifically about it. And if you need help with developing those materials, we're happy to, to provide them to you. Okay, so as part of your training and testing program, with respect
particularly to training. You must have a written training program on emergency preparedness policies and procedures. So again, it's got to be documented. You have to be able to present it, or should expect to be able to present it. Initial training should be provided during orientation, so your new staff orientation or shortly thereafter. That's the recommendation from the guidance, so as soon as possible, obviously. Your per diem staff, if you have any agency nursing staff there, and any other individuals who provide services on an intermittent basis would be expected to assist during an emergency, must also receive the emergency preparedness training too. So again, this gets to the point where a surveyor walks into the door, they might pick anybody and ask what their role is in an emergency situation. So that might include also your per diem staff or other interim providers. So the annual training, again, the running theme is the expectation that you'll be revising and modifying your plans, your policies and procedures, and of course your training and testing throughout. So you're incorporating your lessons learned from the most recent exercises, from any real life emergencies that you might have encountered, and during the annual review, your regular annual review is your emergency program. So you're identifying any shortfalls that you want to make up for in your training. So the facility is going to be deciding what level of training each staff member must complete each year, based again on the individual's involvement or expected role during an emergency. So you're training the individual to their specific roles. Don't overtrain or have them responsible for or train them in procedures that they wouldn't be responsible for. Documented external training. So if there are programs out there that are providing this sort of training, may be sufficient to meet some or all of the annual training requirements, depending on specific staff duties during an emergency. So you would be evaluating those programs to make sure that they fit. Don't just send somebody off to some external program if you don't know what it is, and rely on that. And again, document the specific training completed and methods used for demonstrating knowledge of the program. That means the tests. So whatever particular tests that show that they completed the training successfully, that has to be included as well. And that's going to be, that particular test is going to be specific to the format of the training. So the overall testing of the actual emergency plan, not of the training, refers to the participation in the exercises that we've been talking about. To test the emergency plan, and you're doing it at least annually, and you have to have participated in a full-scale community-based exercise or a facility-based exercise if you are unable to find a community-based exercise to participate in. And so you have to do 2 exercises, an additional exercise. And that additional exercise can be community-based, can be facility-based, or can be a tabletop exercise. Obviously, then, the whole purpose of this would be to evaluate and analyze your response to the drills and the exercises, or if there's an actual emergency event, the actual emergency event, and document that. And then from there, revising your emergency plan as needed. So the testing, of course, is intended, and this again is your exercises, your community-based or your facility-based or your tabletop exercises. You're testing the effectiveness of training and also of the overall emergency preparedness program. So you're including drills or exercises that will identify gaps and areas for improvement with respect to your plan. The full-scale exercise is going to be any operations-based drill or exercise that assesses a facility's functional capabilities by simulating a response to an emergency that would impact the facility's operations and communities. To that end, if anyone may have looked into it, they're not talking about full-scale exercises as defined by FEMA or DHS's Homeland Security Exercise and Evaluation Program. So if anybody has run across those are above and beyond what they're talking about here. So the full-scale exercise is not to that extent. In your full-scale exercise also is obviously, again, going to involve multiple agencies, jurisdictions, and disciplines performing functional or operational elements. The tabletop exercise, which is abbreviated in the guidance as TTX, is a group discussion-based exercise. So it is, as you would expect, in kind of an informal setting where you're around a table discussing a hypothetical scenario. You're going to have your senior staff there. You're going to hopefully also be able to involve elected or appointed officials from the community and other key decision-making personnel. So they're used to assess your plans, your policies, and procedures without actually using facility resources, aside obviously from time out of your day. So when planning or participating in exercises, you're going to be considering, again, the physical location of the facility, your responsibilities of the emergency preparedness agency and other facilities, and the needs of the community. So that's when you're creating your exercises, those are all points you're going to be wanting to consider. Each facility, one note here, each facility participating in a community-based exercise is responsible for documenting its compliance and retaining that information for at least 3 years. So what that's getting to is the facility is individually responsible for documenting their participation in the exercise. It's not enough to say, I participated in this citywide or townwide exercise in 2018, and you can check somebody else's information on that. You obviously have to have your own and your own lessons learned and that sort of thing. If you're unable to identify a full-scale community-based exercise, then you are to conduct an individual facility-based exercise, and then document an emergency that required full activation of your emergency plan, or conduct a smaller community-based exercise with other nearby facilities. So those are other options if you can't do a full-scale community exercise. You still have to attempt to do it. So you have to document your attempts to participate in a full-scale community-based exercise. You have to include, in doing so, include the date and the people that you contacted in trying to put together or trying to participate in a full-scale community-based exercise. So ensure that you do that if you're not able to get into a full-scale community-based exercise.
Right. So, for example, if you can't do one, then you might want to send a letter to, like I said, to the County Department of Health or to the local hospital or somebody like that, saying, we're required to do this on the CMS. Do you want to do this on, November 25th? Mm-hmm. And if you get nothing back, at least keep a copy of the records that you sent it out and the letters that you tried to get them to do it.
Right. And the specific person you asked too. So follow-up can be taken. But so, and after the testing, what you're documenting, of course, is your lessons learned. So the guidance suggests an actionable after-action report, or AAR, which would describe what was supposed to happen, what actually happened, what went well, what the facility can do differently or improve upon, and a plan with timelines for incorporating necessary improvement. So there is an exemption to the training or to the testing, obviously, which would be the actual emergency event, and the response that did require the activation of your emergency plan. So that would meet your annual exercise requirement. So that exemption then lasts for 1 year following the actual event. Of course, the emergency itself and the response must be documented. Just to go back to the AAR, just to explain that a little bit further, that's developed through an after-action review process, which might involve roundtable discussion, which includes the leadership, department leads, and critical staff to identify and then document in your official AAR the lessons learned from the testing and necessary improvements to be made then. So again, that's an actual discussion to be had after to document the lessons learned. And again, one last time, the training and testing program, like everything else, must be reviewed and updated at least annually or more often as needed.
Okay, so we're kind of out of time. We won't be able to get to the Q&A, but we will respond after if you submitted one. Just two other things to keep in mind as you leave. First is most FQHCs that I know of, at least, have in place transfer and affiliation agreements with hospitals which deal with being able to transfer patients. So many of the requirements here for if you have to send patients out of your facility to the hospital may be addressed in those agreements, or you may want to supplement those agreements to address it. Also, importantly, when you're doing this work, included in your risk management and QA meetings, so that for FTCA purposes, you'll get credit for that as well, because this is definitely risk management. And so this might avoid you having to have many other meetings, because you'll have these meetings as well. Thank you to everyone for participating.